All right, let's jump right into a really fascinating parasite, Entamoeba histolytica. In this explainer, we're going to break down its life cycle and its pretty incredible strategy for causing disease. We'll focus first on how it takes over the intestine and creates its famous signature wound. Then, in the next part, we'll follow it as it breaks out and travels to other parts of the body.
You know, when your name literally means tissue dissolving, you got a lot to live up to. It's a heck of a reputation. So how does this little single-celled organism actually earn that name? Well, it all starts with its clever double life.
Okay, so to really get a handle on this parasite, you've got to understand that it's basically a master of disguise. It exists in two totally different forms during its life cycle, and believe me, each one has a very specific and very different job to do.
And here they are. This is really the parasite's whole strategy in a nutshell. It's like a tale of two completely different characters. On one side, you've got the cyst. Think of it as a tiny armored transport pod. It's got this tough wall that lets it survive pretty much anything, including our stomach acid. This is how it gets from person to person. But then you have the trophozoite. This is the invader. It's fragile, can't survive outside the body, but once it's released, this is the active, moving, tissue-dissolving machine that causes all the trouble. So here's how the whole thing plays out. It all starts when you accidentally ingest one of these super tough cysts. It sails right through the stomach, no problem, and then it transforms, releasing the aggressive trophozoids that go and set up camp in the large intestine. Now for most people, maybe 90% of infections, that's where the story ends. They just hang out. But the real question, the multi-million-dollar question, is what happens in that other 10%? What is it that flips the switch and turns this quiet colonizer into a full-blown invader?
So to understand why that invasion is so devastating, we need to kind of pop the hood and look at the parasite's molecular toolkit. I mean, what exactly gives it this crazy power to just dissolve our tissue?
And wow, what a toolkit it is. The trophozoid doesn't just, passively bump into things. It comes armed to the teeth with this whole arsenal of molecular weapons. It's like a special ops soldier with a very specific set of tools, each one designed for a different part of the job. From sticking to our cells to literally punching holes right through them.
Okay, so the first step, and this is absolutely crucial, is just sticking to the target. The parasite uses this molecule called GalNAc lectin that's basically like molecular Velcro. It has to latch onto our intestinal cells. If it can't do this, the whole invasion falls apart before it even begins. It's the non-negotiable first move.
All right, so once it's latched on, the amoeba brings out the heavy artillery, these things called amebapores. And just think of them as molecular hole punches. The parasite secretes them, they poke themselves into the membrane of our cells and create these tiny little pores. Water rushes in, the cell swells up, and bang, it explodes. It's a brutal but incredibly effective way to kill cells.
So now we've seen the weapons. Let's connect the dots and see what kind of damage they actually do in the colon. Because this combination of sticking, dissolving, and killing creates a very, very specific type of wound. A wound so unique it's considered the hallmark of this entire disease.
So the big question is, how does this one tiny cell create such a distinctive wound? Well, the secret isn't just in what it destroys. It's really about the path it decides to take as it moves through our tissue. Okay, check this out. It's a brilliant, if sinister, strategy. The trophozoid first blasts a tiny little pinhole through the surface layer of the colon. But once it gets inside, it finds itself in the submucosa, which is a much looser, easier layer of tissue to get through. It's just easier to move sideways than it is to keep pushing deeper. So it spreads out laterally, creating this huge area of destruction underneath that tiny little opening. And that's what gives you the classic flask-shaped ulcer, a narrow neck on top with a big, wide base of dead tissue below. It's a dead giveaway for pathologists.
Now, all of this tissue destruction leads to something really weird, kind of paradoxical, actually. You'd think with all this chaos going on, our immune system would be going absolutely berserk, right?
I mean, normally, an invasion like this would be a 5-alarm fire for the immune system. We'd expect to see swarms of neutrophils, our immune system's first responders, rushing to the scene. But when you actually look at the tissue in amebiasis, the picture is just different. The first responders seem to be missing in action. So, where are they?
And here's the crazy part. The neutrophils do show up for the fight, but the parasite is ready for them. It uses those same amebapores we just talked about to kill the immune cells the second they arrive. The would-be rescuers become victims themselves, which explains why there's this weird lack of inflammation right at the site of the invasion.
And this brings us to an absolutely critical point for anyone in the clinic. When a patient comes in with bloody diarrhea or dysentery, you have to be able to tell the difference between a bug like Shigella and this amoeba. And these clues are how you do it. See, bacterial dysentery usually hits fast, with a high fever, and if you look at the stool, it is packed with neutrophils. Amebiasis? Totally different. It's a gradual start, not much of a fever, and almost no neutrophils in the stool, because the parasite killed them. This difference is everything for getting the diagnosis right.
But the story doesn't always end in the colon. Sometimes the trophozoite's tissue-dissolving rampage goes a little too far. It can actually chew its way right into a blood vessel. And once it gets into the circulation, it can get swept away to anywhere in the body, which leads to a whole new level of dangerous, systemic disease.
So there you have it. That is the masterclass in invasion from Entamoeba histolytica, from its two-phase life cycle to the molecular weapons it uses to carve out that signature ulcer. Make sure you subscribe and stick around for our next explainer, where we're going to follow this parasite as it escapes the gut and see what happens next.
All right, now continuing with the extraintestinal spread of Entamoeba histolytica, we're going to dive into its most serious and honestly most fascinating complication, the liver abscess. We've seen the damage this parasite can do in the gut, but what happens when it breaks out? Let's follow its path and really understand the destruction it leaves behind.
So once those trophozoites chew through the intestinal wall, they get access to the submucosal blood vessels. And that, right there, is their ticket out. It gives them a direct, straight shot to one of the body's most vital organs, the liver, our metabolic command center.
You know, this journey is a textbook case of hematogenous spreading through the blood. The trophozoites literally invade the blood vessels and get swept up into the portal circulation. You can think of this huge network of veins as a superhighway, pulling all the blood from the gut and funneling it directly into the liver. The parasites just hitch a ride, eventually getting stuck in the liver's tiny blood vessels, the sinusoids, and that's where they set up shop.
And when you think about it, this makes total sense, right? The liver's whole job is to filter everything that comes from our intestines, and unfortunately, that includes these parasites. This very function is what makes it so vulnerable, and by far the most common place for E. histolytica to land once it goes systemic.
Now this is where it gets really specific. Check this out. About 80% of these abscesses show up in the right lobe of the liver. So you gotta ask, why? Well, it all comes down to plumbing, really. The dynamics of blood flow. The right lobe gets the lion's share of the portal blood, especially from the parts of the colon where the amoebas are most active. More blood flow just means more parasites are getting delivered to that one spot.
Okay, so the parasite has arrived. What kind of mess does it make? Well, the lesion it creates is weird. It's totally unlike a typical bacterial abscess. It has this very unique and, I'll be honest, kind of unforgettable pathology.
See, an amoebic liver abscess isn't a bag of pus like we normally think of an abscess. No, it's an area of liquefactive necrosis. The parasite's name itself, histolytica, literally means tissue dissolving. It spits out this nasty cocktail of powerful enzymes that just digest the liver tissue, creating a cavity that's filled with the soupy remains of dead liver cells.
And this brings us to one of the most classic, and maybe slightly gross descriptions in all of pathology. The gunk they pull out of these abscesses is famously described as looking like anchovy paste or chocolate sauce. Now that's not just for shock value, it's a huge diagnostic clue. It tells you this is a lytic process, not a pyogenic one. It's this reddish-brown, thick stuff made of liquefied liver cells, not dead white blood cells. So let's really hammer this point home. A bacterial or pyogenic abscess is a war zone. It's full of pus, which is basically a graveyard of neutrophils that died fighting the bacteria. But E. histolytica plays dirty. It actively kills the neutrophils that show up to fight. So what you get is a lesion with surprisingly few inflammatory cells. It's just destruction caused by the parasite's flesh-dissolving enzymes.
So what does this look like in a patient? Well, they're going to be sick. We're talking high-grade fevers, a constant dull ache in that upper right part of their belly, and sometimes that pain even radiates up to their right shoulder. You'll find a tender, enlarged liver on exam. But here is the absolute #1 clinical pearl you have to remember. Most patients with a liver abscess don't have diarrhea when they show up. The gut infection could have been weeks, months, or even years ago, and it might have been totally silent.
Given how dangerous this is, how do we fight back? Well, the treatment strategy is actually pretty brilliant. It's a perfect example of targeting a bug based on its lifestyle. It's what I like to call a targeted two-phase takedown. The strategy has to have two parts, simply because the parasite is living in two different places at once. First, you've got to kill the invasive trophozoites that are actively destroying the liver. That's the emergency.
But second, and this is just as critical, you must wipe out the cysts that are still hanging out in the intestine. If you only do the first part, the patient is guaranteed to relapse. Both steps are non-negotiable for a cure.
Now, the drug of choice for the invasive tissue-destroying part of the infection is metronidazole. It's a workhorse. It gets activated inside the amoeba and generates these toxic free radicals that just shred the parasite's DNA. It is incredibly good at killing trophozoites in the liver.
And this all leads us to the single most important teaching point in treating amebiasis. It's a question that every single clinician needs to have a rock-solid answer for. Why exactly do we need two drugs?
So let's just put the question out there. If metronidazole is such a rock star in the liver, wiping out this life-threatening infection, why can't we just stop there? Why is that second drug an absolute must?
And boom, this slide tells the whole story. It's all about pharmacology. It's about where the drugs go in the body. Metronidazole works so well in the liver because it gets absorbed into your bloodstream and reaches high concentrations in your tissues. But because it gets absorbed, it barely reaches any effective concentration inside your gut. The second drug, something like paramomycin, is the complete opposite. It's not absorbed at all. It stays right there in the intestine, reaching super high levels that are lethal to the cysts and any trophozoites still there.
So here's the bottom line. While metronidazole is busy saving the liver, it's basically useless against that reservoir of cysts just chilling in the colon. And those cysts, they're the source of the next infection, and they're what the patient is shedding to infect other people.
And that's the punchline. If you only use metronidazole, you've handled the immediate crisis, but you haven't actually cured the patient. You've just left them as an asymptomatic carrier, totally ready to get sick all over again, or to pass the parasite along. Following up with a luminal agent like paramycin isn't optional, it's mandatory.
So the big takeaway here is really simple and easy to remember. To beat Amoeba histolytica, you have to remember this mantra. 2 locations, the tissues and the gut lumen. 2 forms, the invasive trophozoite and the transmissible cyst. And therefore, it always requires 2 different drugs. Simple as that.
And that pretty much wraps up our look at the amoebic liver abscess and how we manage it. If you found this breakdown helpful for connecting the dots, please do us a solid and hit that like and subscribe button for more custom medical videos made just for you.